It didn't fix it. Can you go and bring this down so the lip is in the center of the screen? Yeah, or just even if you go forward and backward, it will go up and the black and white TV. Yeah. Okay, come here. Yeah, today we are doing a simultaneous session with an ongoing case, which we are doing immediate loading, and we are discussing the effect of PRF on soft tissue and in the aesthetic zone. The difference today, we are going to apply a concept, we called it 2-second rule. Basically, we are going to ask you to tell us what you think we are doing at certain step and what should be done the next step, back and forth. All right. So now this is the case. The patient has come. She is born in 1970. That means how old is she? 40, 48 years old, lady. And she is first concerned about the central incisor, and she is thinking about the posterior occlusion, but for now she wants to replace the tooth number 21. Any questions regarding the radiograph? The patient has lost the central incisor, and she is now at the moment she wants to replace the central incisor. Any questions on the radiograph? Okay, so this is the way the patient is presenting with. What are the concerns you can see here? The labial frenum. The frenum is missing. Okay. Okay. And what about the frenum? You said something about frenum and then you stopped. And what about the? Is there a term for this? Is this called recession or there is another term? Well, you see something also here. Papilla is here, my dear. Okay. This is an occlusal view to show you there is also slight soft tissue, yeah, depression on the soft tissue as well. Yeah, the biotype looks thick. To show you her other teeth, just to have an idea of the patient's habits in terms of cleaning, brushing, maintaining, types of fillings. You can see that amalgam. So most probably it's been a long time. We can't tell because some countries still using amalgam, but generally nowadays, especially ladies, they will not accept a metal, which is a filling. You can see the tooth requires some kind of a restoration. There's slight attrition. I agree with you. We can see cavity on the occlusal surface and an old amalgam filling which is corroded already. So you're looking at a patient who is not very much keeping update with the routine checkup and cleanup, but she is now concerned about a certain aesthetic zone, which is the anterior central. Yes. And you can see the occlusion. She is still class 1, but there is a resorption of the soft tissue. So now this is how she is. And the smile line is not very helpful because you can see the neck of the gingiva at the neck of the teeth. So it's basically, we have to be more cautious in these patients. Uh, how, It can be just early, I mean, not very gummy smile, but you're right. So, no, no, it's not inflamed. It's just her lip is high, so she has a high lip line. That's the better terminology. There is a term, I think it's a cliff or something. Uh, uh, yeah, she has a deep bite. So the position of the implant, if you want to think of the restoration, you have to be careful what kind of position you're placing to leave enough room for the abutment. As you can see on the second screen, they are immediately loading live. This is live. They are using a vacuum form on top of two abutments, and that vacuum form will help to shape the mold for the composite uh, mixed with acrylic material. It's not PMMA, it's a hard PMMA, and it's going to be screw retained. Okay, yeah, now it's fine. Anteriorly, we extracted four, the centrals and the laterals. Okay, this is the part I wanted you to start talking. Hayan, you will tell us step by step what is going on and what you think should be the next step. We are starting the surgery at 5:30 p.m. The room temperature is 23. I think 22 to 24 is ideal, uh, and that's it. It's um, now what is happening now. This is a surgery session. You tell me what's happening and what is next step. No, no, this is during surgery now. Yeah, pre-surgery. Okay, okay, okay. Mm-hmm. 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 Okay, wait, wait. So, okay. One thing about the first stage is the mesodistal width of the central should be measured if this is bigger. If it is bigger, then there might be an issue either with the midline or the symmetrical copying of the tooth. So always a wax up in this case will help. Otherwise, if the sizes are different and we are not predicting it before, or we are not explaining to the patient, it might create a problem. Okay, now what? Now you tell me what's going on and what's the next step. So anesthesia is done. Uh-huh. Hmm. What kind of incision is this? Is it a crystal incision? Yeah, is it from papilla to papilla or is it avoiding the papilla? Okay. Uh, okay. Do you prefer if we would have avoided the papilla or you think? Okay. Okay. Well, this you see now, but this you didn't know before. This is a surprise. So that's later. I'm talking about the Chris. You're right, because we were thinking maybe we can repair this area. So we needed to actually reflect to see what is going on. In the diagnosis phase, we didn't like this triangle showing. Okay, so what's next? Osteotomy is straight. Okay, okay, okay. Sachin, what is going on now? Uh-huh. Okay. Uh-huh. Yeah. And what's next? Okay. Hmm. Probably we would not have done it if we didn't have such a defect, because the more you reflect, the more bone resorption you get. But since you have a defect, you have to expose it to fix it. What is next step? So we are thinking immediately, yeah. I just have to interrupt to go to the screen on the right. As you can see, the abutments are silver in color, and when we make immediate loading, this silver does not reflect very well when it's covered with composite. It gives a grayish look. So we cover it, as you can see, with the reason they switched off the light, because this is a light cure material. We cover it with the opaquer and very thin. This he's doing it thicker, but a thin layer of opaquer is enough to stop the silver from reflecting. So when you cover this with acrylic or composite, that grayness is not there, even though it's a temporary, but it can be there for like 3 months. So it can look very nice if you add that, and that's what is going on the right screen. Anyway, let's go back. It's a light cure opaque. Yeah. All right. So what the next step is? So you are not doing the implant first. You're doing the grafting first. Because if you do the grafting first, and then you are doing osteotomy with the irrigation, you might lose all the things. So it's better to, if you're planning to postpone the whole thing, I agree with you. Shaib, it's okay. No, no, it's fine. So basically, we are just estimating the size of the defect, so we know how much we require to have, and also what material it's going to be. Is it going to be self-setting? Is it going to be with membrane, with tack, without tack? PRF is needed, not needed, soft tissues. So all that is now being, when we put the soft tissue back, because we're going to do augmentation, we are thinking of scoring should be done, definitely. Okay, what else? What's next? Frenectomy can be easily added, so it will have less pull effect on the grafting. Your turn. What's next? Here, while closing. Okay. But how can we fix that? Soft tissue graft at this stage. Mhm. Possible, possible. You can do it that way. Why not? It's a good idea. So we are going more distally, as you said, to see how big is the defect and what can we do with the defect. So if we have to cover, we cover more. As you can see, there is bone graft here. And if you put any bony material here on the dentin, you know it's not going to stay. So, but at least we wanted to see the end of this defect, and now we can visualize it. Okay, what's next? Okay, okay, okay. Yeah, blood is collected, the osteotomy, whatever bone is around the drills. So we don't go with a very fast speed osteotomy. We can collect the bone as we are doing the osteotomy. And we are trying to avoid the defect while doing the osteotomy. as you can see here. Yeah. What's next? Based on the bone quality, we could decide to, because of the softness, because we want, good stability. We are not doing immediate loading, but because of the graft. But you're right, we want to minimize the chances of less primary stability. Okay. After the osteotomy, placing the implant, selecting the size and shape. Now, uh, you can tell what's the size by the neck, or it's difficult for you? Probably it's difficult for you. This is a 3.2 by, yeah, either 11.5 or 13 millimeter. And because we want the maximum bone thickness buccally and palatally, we had to decide between a 4 millimeter implant or a 3.7 and get less buccal bone versus use a slightly narrower implant and get more bone buccally. On the right screen, you can see what he's doing. He's placing a Teflon on the soft tissue, so the acrylic will not interfere with his suture material, or it will not enter and stay in the soft tissue area. So what's next on the surgery side? Okay, so place the implant, and the implant should be 3 millimeter below the CEJ of the neighboring teeth. CEJ is the same CEJ, but because it's receded, maybe slightly, maybe, yeah, somewhere, yeah, 3 millimeter below the, yeah. Mhm. What is this for, this photograph? To see if we could, for what? Final, or, yeah, finish the sentence. Final restoration, what? Which is, what's the, exactly. This photograph is mainly to decide if this case can be restored with a screw retained, or we have to use a cementable. As you can see, it is not palatally placed because of the position of the bone, and it will be cementable. The size is 3.2 by 13, which is a long implant because of the diameter. And now we are decided to do a bone augmentation on the defect area. We are using a material which is mixture of HA and tricalcium phosphate on the defect buccally. What's next? Actually, this material doesn't need a membrane. So it can be kept open because it sets. But because of the soft tissue defect, which we have here already, we are thinking of PRF. So we are using a PRF to cover the bone material. This is the EasyGraft crystal from Switzerland, which we use as a bone material, and then we are covering it with, we are also placing the patient's own bone, the autogenous bone, on the, no, the defect is filled with this material, just at the uh, patient's own dentin. We know this is going to resorb. It's just a filler, which we hope will be replaced by the patient's own bone. We never know what's going to happen to this. We are 100% sure it's going to disappear. But by the time it disappears, we don't know what's going to replace it. We hope it will be replaced by some kind of bone. That's why we are using autogenous bone here at this area. So what's next? Okay, so PRF, okay. So we are placing the, as you can see, we're starting from all the way, especially we are worried about the neck of the uh, tooth number 11 of dentine exposed area. That is more of a soft tissue defect than this one. We're covering everything, but this is our main problem. Even though the patient did not come for this and we are not treating this, but because the area is exposed, because we already opened it, we might as well try to uh, make it in a, at least we don't make it worse. As much as possible, we try to do it. She suggested that we do a soft tissue graft. I think at this point we have to do one thing. We cannot do multiple procedures because the soft tissue coverage will be very difficult unless you planned it before. Normally, a soft tissue is used in the middle of the connective tissue, not when you reflect the full thickness flap. The best place to put a soft tissue graft is in the connective tissue. That means you leave the periosteum, you just stick in the connective tissue area. Now we already cut the blood supply so this is not the best time to do a soft tissue graft. That took quite. So what's next now? You can see the graft is being covered. The autogenous bone is placed on the dentin. As you pull the soft tissue, you're sure this is anyway going to come a little lower, and it's going to cover the neck of the dentin. That's a good point. We should score. I think we did. Yeah. There are two ways of doing it. If you do it now, the bleeding is going to disturb your vision. If you're sure you need it, it's better to do it as early as possible. Because by the time that the real bleeding has stopped, so it's easier for you to see instead of doing it now and then there's a lot of bleeding going on. So that's the suture on the, is it the same day? 4-3, 4-3, yeah. Now this is after the suture is over. As you can see, this area we know it's covered with PRF. As you can see, the defect is still there, but because of the material underneath, we hope that the soft tissue will improve.
Why we didn't use a membrane? Like, for example, we could use the guided bone regeneration. Like we make a big membrane.
We could use a membrane also. But what we did is also a valid method of doing such cases. We placed TCP with HA, and we covered it with PRF. It's also very nice to do. The result is very good. On the right screen, as you can see now, already the area is temporized and for immediate loading. Now the criteria for immediate, you don't mind me jumping back and forth? No, no, it's okay, have a seat. You don't mind I'm jumping back and forth from right to left because I don't want you to miss the small issues on the right screen. What he's doing now, because he's above 40 Newton centimeter, 45 Newton centimeter, he is able to do an immediate loading, as we can see right now. So, but to be safer, we would like to have it at least 1 millimeter of occlusion. That doesn't mean if she eats an apple, it's not going to load. Still, it's going to load. Any food comes in between, it's going to load. But at least when she is swallowing, when she's closing, when she's talking, all that time, um, she is not loading those implants. The second thing is the diet criteria for immediate loading, even though it's not published anywhere, but that's what we've been using is the first week is what is soft? So it's liquid, not soft. The second week is anything that goes in a mixer, like a paste, like, baby food kind of, but any food she wants. The third step or the third week is some kind of a rice with some kind of a gravy. And the fourth week, she's on her own. So even though we have good primary stability, still we think diet plays a role in, keeping everything slowly loaded, gradually loaded. Coming back on the left screen, this is at the time of suture, uh, um, suturing. Repeat. Yeah, yeah. We wanted to get a better closure, so it was very actually useful to have a releasing incision on the frenum. This is the occlusal surface. I think this is a. You want to guess? Yeah, this is gingy gel. We, as a protocol, we apply it after the suture. And the occlusal surface shows that we even made an incision at the papilla in the central, distal to central. Now, this was on the 4th of March. This is on the why 19? Because there is a big bone augmentation. 1 week is not enough for this to heal. The bulginess is a good news because uh, the redness is not a very good news, but the bulginess is a good news. And the good thing is the redness is only at the suture area, which means the suture is the cause. There is not total inflammation going on everywhere. And we know suture collects food, so we are removing it and that redness will go away. And this is after we removed it. You can see, but this is not permanent. I don't think this will be permanent because frenum is released, but because the PRF increases the blood supply to the area. But how long they live, the platelets and the PRF? 11 days. So I don't think we're going to get anything after, 1 or 2 months. I don't think this looks very good for me to see, to tell you that uh, I'm just looking at the right screen at what he's doing. He's uh, he's trying to remove the bridge, I think, to polish it. Okay, uh, so this area is the incision line, as you can see, and the papilla was preserved. This papilla is back, which is good news. This papilla is back, which is good news. And this is slightly better than before, which is, I think it's because of the PRF. 5:30 was when we, okay,
Question, the phyllectomy, it was done during the surgery,
yes,
the flap.
yes,
We just cut the frenum.
just cut the frenum, but as little deeper than just cut the frenum. We didn't do the Z shape to remove the total
Just an
frenum.
incision.
We just made a deep incision to release the stress or the pull effect of the frenum.
And did we like cover it with anything?
Nothing. We normally don't cover it with anything. The patient comes after, you remember the date? So the patient comes on when? Hmm? How long? Why? Exactly. Once the bone is there, the protocol of anything less than 6 months is little hasty. Hasty is a good term? No, hasty means if you are in a hurry. Yeah, I think once you start doing bone grafting, it's better to give it the full maturity time and not do things less than 6 months. Okay, you can see the shape. You can see the still the dentin is exposed, but you remember that V shape that is gone. So actually, it was in a good result compared to what she had before with that V-shaped defect. You can see that it's more of a curve shape than a V shape. Yeah. I think you can see it here, but that V shape is gone. The gum has healed in a circular way, but the dentin, of course, exposed dentin will remain exposed dentin. I don't think we can do much about it unless uh, we try to put a soft tissue graft and pull the graft downward by making some stoppers on the teeth and suture this graft to the tooth by pulling it downward. I repeat, after everything heals, if you want to repair this, you can place a soft tissue graft uh, and the sutures can pull the graft downward, and by composite, you can glue the suture to the tooth to keep it. Otherwise, the soft tissue will, as the patient speaks and the muscles, the soft tissue goes up again. And you have to keep it down for sometimes up to 3 months. But you have to use very thin sutures, and that's it. Gly- Glycolic, polyglycolic is one of the best sutures. Monofilament is one of the best sutures for such techniques. 5-0 or 6-0. Sorry, Vicryl is bicrylic. These are monofilaments. The one we use, no. The monofilaments, PDS, monocryl. Mm. Those are better for such because it's going to stay a long time. We don't want food to collect around them, so it should be monofilaments. Shade is selected. Of course, it's very difficult because of the stains. Well, I don't know if she had it, so we have to make sure we don't give her a diastema, even though the space on the right is bigger than the space for tooth number 11. That's why this is a little tricky. Now, this is uncovery stage. I want somebody to tell me what we're, okay, palatally placed incision, and then, so you suggest the next step will be we make a cut here, and we make a cut here. Okay. Anybody has another idea? Yeah, but the single horizontal up to the papilla. But if you, I agree till this part, but if you make that incision and you want to expose the dentin, don't you think it will tear? Expose the implant. Hmm. Okay, let's see what we did here. Yeah, what we did here was the the it is palatal. This is, if this is the crest, we are palatal, as you can see. Yeah, clear? No? Okay, on the right. Okay. This is slightly palatal, but because we don't want to do we want to avoid this line to be seen here and here. So what we do, palatally, we make a C shape or a U shape. Keeping in mind, this U shape is exactly palatal or touching the palatal corner of the implant. So if I push this blade inside, I'll be touching the implant palatal corner. Okay. Actually, this is my favorite technique now. For all the aesthetic cases, now I do this. Some patients come with a thick gum, I cannot elevate it. Then I will use my curved blade, go inside, not from outside. From inside, I start cutting, underestimating or releasing. Yeah, till I can get the implant exposed. Now this is a periosteal elevator. I'm trying to basically tear away any soft tissue adherent to the bone, buccally and palatally, but I avoided that line, the H line. I still do the H line for the posterior, H-shaped incision for uncovering the. Why am I? You okay? Uncovering the posterior teeth. For the anterior, now I'm leaning more towards this technique. Now, if you can see the screwdriver, I found the access hole for the center of the implant. So probably when I open the screw cannot come out. So I have to use an artery forceps to pull it palatally. But at least I can push this area slowly buccally versus tearing it. And if I cannot push it buccally, then I'll make a small cut from here and here, but from inside, not from outside. So now I know I got my hole. I can see the soft tissue buccally. If I can have that, I know I will have a nice margin around the neck of my future restoration. And you can see the angle of the screwdriver. Definitely, this is not a screw retained prosthesis. This is the abutment or the impression coping. As you can see, it's placed acceptable, but it's still not good for screw retain. You can see how the soft tissue now is thick and papilla is preserved. Impression is open tray. You can make it closed tray, but open tray is definitely always more accurate and less chance of error. One of the oral exam last week, they asked one of the doctors, why would you use an open tray versus a closed tray? And he had difficulty in answering the question. The question is, I prefer an open tray all the time. If I cannot, then I will use something with less accuracy. But I think open tray will be ideal for all the cases. If you no, you can use it for fixed. Uh, uh, but if you have a single crown and you are sure that soft tissue and everything is in a way that there is enough soft tissue, enough impression material that can grab on to the parts for the impression, then you can go for a single crown closed tray. But if the implant is very deep and all these parts are very deep, the impression material, if it's not catching anything much, then it's definitely, you're not sure when you put it back with your hand how accurate will be that. So that's why, um, if you are in doubt, you always go with open tray. I think we saw all this. Okay. So we are done with the uncovery and impression. Not always the uncovery and impression are in the same visit. Sometimes we do uncovery, we place a healing abutment, we wait few weeks, and then we take the impression. Sometimes, if you take the impression during the surgery, you do the uncovery, you place your provisional, and you still don't take the impression. You wait 3 weeks, and then you call the patient, and then you take the final impression. That's also one protocol. Yes, exactly. Especially with thin biotype that you don't know where it's going to land, the final margin. That's what. Now, this is 12, 10. We got the crown from the lab with that impression. Now, the labs mostly, they have no clue about periimplantitis. They have no clue about biological width. You get my point? So the crown they make is generally based on where is the implant. So they take the ceramic all the way to the end of the abutment. That's how they look at your case. Yeah? So this is how they looked at the case. This is where the crown is. This is where the neighboring is. And that's what they send us. This is the abutment being milled by the lab. This is the patient. This is the healing in place. This is not the cover screw. This is the healing. Okay. I still think this is much better than the way she came with. What do you think? Now we placed the crown in place. Two things. One is the diastema. Even though he tried to take the same width, but because of the diastema, it looks awkward. And if you see this whiteness, see how white is the gum? Guess why? See, it's white here. Why? Why? Because the gum is still here, and the crown is going till here. The ceramic. Yeah. See the color? So these two things have to be managed. One is we have to remove all the ceramic, fill the gum area. Any ceramic which is here has to be cut, and he has to find some trick. Well, reduce it and fully is. There should be no pressure on the gum. And also the diastema has to be rectified. You can see, and also slightly rotated. Doesn't look, even though it was a closed tray, but it's not very aesthetically thing. So when we do a pickup impression, you can see the margin of the gingiva, right? Correct? Why you're doubting? See this line? You see this line? That's the margin of the gingiva, right? So anything white under that has to go. So all this ceramic has to go. You might think, wow, that's a lot of ceramic, but that's the best way. So all this ceramic goes away so the gum can feel comfortable. Well, you can leave 1 millimeter below the gingiva, that's all you can leave. But you don't need all this ceramic to push the gum away. Because when you push the gum away, can you push her away? Just push her chair. You will go away. If I push you, you will move. So if the ceramic is pushing the gum has to go away. If not today, maybe 3 months from today. That's why you shouldn't push the gum unnecessarily. So with this, we know where the ceramic should end. Now that was 12. This is 17th, correct? 5 days later. Now the lab has hopefully modified those comments. The diastema is closed, the height is reduced, the thickness is reduced at the neck, thickness of ceramic, I mean. It's the abutment. And because we know it's a cementable, we have asked for, well, we'll see it on the next slide. And this is how the gum looks like with the healing in place. Okay, this is round. It doesn't look like a neck of a tooth. So the tooth will give it a shape to be more of a triangular shape as the tooth will fit in. So this is now the third visit for the restoration. We did some more modification, and now this is the third visit for the restoration. The midline is better, the shade is better, and the neck is triangular now. And we did some characterization here to match the tooth which she has. Now, what is this? What's this? This is an acrylic material that it's copy of the abutment position. Now, this is the third attempt, which we are thinking this is it. We like this because the gum is not blanched, even though this tooth is defected, but because her gum comes to here, she likes it more than this. Instead of making this one longer and uglier, it matches all her teeth except this one. And this is how it is. And even though you might think, why is it sharp here and here? Actually, this is round. The gum is healing around it now. As we speak, the gum will heal to become circle. But we know the gum is not blanched anymore. See the color? It's not blanching. And the reason for this space, if you remember, the space here is much more than the space here. So we try to camouflage it by making this part come abruptly to the left and slightly forward, so you don't notice that this is much wider than this tooth actually, because the space is bigger. Going back to the right screen, live, what's happening? There's too much light. Okay, when it's clear, we will discuss. I think it's the ending stage of finishing his, let's see if you can you focus the light in a way that we can see? It's too bright for us. Yeah, they did it. They removed it. Oh, it's not there. Okay, probably somebody's polishing the bridge as we speak. Yeah. Okay, back to the case. Now, when we remove the abutment after leaving it for 4 minutes, you can see the shape of the Gum is taking, but when the tooth is in place, you don't see the whiteness. Why? Because it's just a matter of a millimeter. That's it. Just 1 millimeter pressure, not more. Before it was more. That's why it was blanching. Now it's not white, it's just pink. And when we leave it for, say, 4 and 4, say 8 minutes, we can get something like this without pressure. There is pressure, but it's not in a way that it's causing less blood supply to the area and the blanching can be detected. You can see the soft tissue in after 8 minutes. We can check even the time if you want. How many minutes? Let's go back, see the time. This is 3:45,
But doctor, we shouldn't do cementation immediately.
3:46, 3:46. But let's see when she came. 3:40, 36, 37, 44. So 44 it was placed, 45, 46. In 2 minutes, she got this shape. 52 now. Okay, now when we know that there is no blanching, now we want to cement it. She likes this. The midline is okay. The lip line is okay. We ask her to speak the F, not the F word, but the F letter, and the sheen and the seen. Once these three are correct, generally everything is correct. Okay, and this is how it is at 55 minutes. That is how many minutes after the pressure? Yeah. Now it comes the time for cementation. For cementation, we use this cast, where this plastic material is basically a excess remover kind of a thing. What we do, we put cement in the crown, we put it on top of this, immediately we take it out and we put it in the mouth. So all the excess cement will be here instead of subgingiva in the patient's mouth. So we have only enough cement inside the crown. Immediately, you don't have much time. This is like 5 seconds, 10 seconds maximum. You don't have, in 30 seconds, your cement is starting to set. So if you want to spend most of the time cementing in the mouth, say for 20 seconds, you have only 5 to 10 seconds on this part. So you immediately push it in, take it out, wipe the excess, place it in the mouth. So this is very close to the patient's head. This is not in another room or something. And that's it.
And the material they use for cementation?
For this, we use tampon. Yes. Because the lab makes the abutment, so the walls are parallel. See how the soft tissue in few minutes took a shape? It's very, very nice. The reason it's very nice, because it's only 1 millimeter of push, and this will not bleed and it will not be inflamed because it's just a millimeter of push.
Because sometimes in that they make some concavity in the buccal area, so it will.
You can, but where you want to make concavity? There is no room to make concavity. But if you are uh, very subgingival and your abutment is thick, yes. This is a 3.2, so there's not much to concavity. The reason we use the 3.2 is because we don't want to have soft tissue reduction. But if you use a wide implant, it's better to do a concavity here somewhere, subgingival, so the gingiva will be thicker. This is to show you how the soft tissue is forming around the crown if it's within the limits of the pressure. Now, the second part of the presentation, I wanted to, let's see some x-rays of this case. So this is how she came. This is the implant with the bone graft. And this is at the time of uncovery. You remember we are trying to find the implant without making an incision. So this was a probe. When we made that cut, we put a probe, take an x-ray, we know we are in the right place, so we don't have to cut more. Okay, now let's see if the staff, you think she's done? Or maybe should I call them back? Any questions about this case? Maybe Nashat came late. I wanted to show you the defect and the nurses are free, or how many of the nurses are free? Okay, all of them? Which one has a phone? Nitu?
Distance from
I'll call Nitu. Thank you.
how she was the tooth. Accident
She lost the tooth. She told me, I don't remember. This was 2013. I don't remember how she lost it.
what is the reason of this gingival recession in the central?
She presented herself like that, and we tried to fix it with bone graft and PRF, and it were. I mean, it wasn't great. We still have a little bit of recession, but this V we could repair. Let me just call the. But the frenum could be related. The frenum could be. They're definitely related. But the frenum and the thing is not the same. This is the frenum here. This part I agree. This is kind of some, it looks like the tooth is rotated or something. The next part of the presentation is a little more scientific. So you have to, and if you got a chance to go over the links I sent you.
Yeah, I saw a T helper and H helper. So much information.
Yeah, that we're gonna bring that today. It's good to know what's going on. So after this entertainment case, we actually let's talk about future science in implantology. I just wanted my nurses to be here because it helps them during the understanding of our peri-implantitis case. Trying to call them. Well, let's play. Manly, you are with the girls in the food court, or you're in the clinic? Oh, I'm calling the nurses. Nobody's answering. I wanted them to come. You know who has a phone beside Nadine and Nitu? Sheila, okay.
Cell receptors, we call it T cell.
Pindutin ang 1 para sa colored shorts na dying inside the whole view ni Garrett and Panto. Pero, Doctor.
Sheila, can three of you come to the lecture hall with your lunch? Thank you. Okay, what we want to talk about, let us turn on some light, and then we want to talk about cases that patients come and they place implants. They come with a periodontal problem. Patient come with a bone resorption, okay, around the teeth, and that made the teeth mobile, correct? Because of the bony defect and the mobility of the tooth, you decide that it's not worth doing root canal treatment, periosurgery. Better to extract the tooth, do augmentation, place an implant, and solve the problem, correct? This was correct till 10 years ago. Since then, the periimplantitis cases has become approximately 20 to 25% of our cases now. That means in every 4 patients, one of them will have some kind of a complication that you have to fix. Now, this has made some people to stop placing implants and concentrate on why this happens. Why this happens? Why for 75% of people, once you put the bone graft and then implant, everything goes smoothly. But for this group of people, the same thing that happened with the teeth, it happens with the implant again. Now, today, this last 1 hour, we want to talk about this group of people. Okay? So, one thing I want you to pay attention is doxycycline. What does it do when you take it, say, 100 milligrams or 250 milligrams? What does it do? Okay. So what does it do? So it's an antibiotic. Yeah? Okay. What is the average? Have a seat. What is the dosage for a daily dosage of doxycycline? Huh? Okay. Sorry? Okay. Once a day. So the patient is taking 100 milligram once a day for 7 to 10 days, right? Okay. When you reduce this 100 to 20, does it kill any bacteria? No. What does it do? It enhances the collagen formation. So it totally has another effect on the collagen formation. That's one information add in your cell. The second thing is chlorhexidine. We have it in 1.2, 1.8, or 2%, right? What does it do? It kills the bacteria. If it stays there, it kills the bacteria. And if it's washed off, it can stay up to 6 hours. Some books say up to 8 hours. Okay? Now, if you increase this dosage from 1.2 or 1.8, what is available now here in the market? 2%. 0.12. 0.12, that's a mouthwash. I'm talking about uh, the killing the bacteria. Now, if you increase this to 10, okay, once it's increased to that level, it will kill any bacteria totally. But it should be only inside the crevice of the peri-implant area for it not to uh, uh, basically stain. It will stain the teeth, but for it not to be, yeah, for the patient not to keep drinking it or eating it, or so it has to be. So now this is available in a varnish format. It's like a varnish, okay? So you have something to build collagen, and you have another thing which will kill the bacteria. Now, the third element I want to talk about is something called CD4 and CD8. Any of you are familiar with these terms? Repeat. Yes, yes, continue. Okay. Okay, now we'll watch a 2 or 3 minute video, and after that, we will see if from now on, when a patient comes with a periodontal disease, maybe our protocol will be sending them plus the vitamin D. The reason I wanted the nurses to be here, you have to be familiar with this. You have to be familiar with the CD4 and CD8 because the patient will ask you, because it's not a cheap test. The patient will ask you, why should I do this test? And if you're not comfortable, then the patient will have, will not be. If you know why you're doing this test, then the patient also will understand that you're doing it for a reason. So I'll explain any part which is not clear after the
terms. So there's two types of T cells, just like that. All T cells have T cell receptors. We draw the T cell receptors. T cell receptors, just like that. But they also have these other proteins on them. And some of them have these proteins called, I'll draw it like that, called CD4 proteins. And some of them have a different color. And some of them have what's called CD8. CD8. So this one right here we call a CD8 positive T cell. It has the CD8 protein on it. This would be called a CD4 positive. CD4 positive T cell. I've never used these words before. You're like, hey, where did this come from? Now, the CD4 receptor is the thing that wants to bind. This is the thing that helps to go to the NHC2 complexes. So most CD4 T cells are helper T cells. So this is, most of the time, and I want to make it very clear, immunology is a very, this deal, people are discovering things on a regular basis, so people are still understanding these things, and there are all sorts of special cases. But usually when people are talking about CD4 positive T cells, they're talking about helper T cells. So this is one going to be a helper T cell. or you can call it T helper, just like that.
I saw.
Likewise,
They want him. They want me.
proteins, these are attracted to the MHC.
His microphone is off. Yeah, I can definitely see everything. It's good. If the patient is happy with it, it's great. If you want to polish it more because the light is off here, we don't see how shiny it is. But if it's 1 millimeter out of occlusion, it will be perfect because I cannot see the 1 millimeter from here. And that's it. We just hope that she likes it. Otherwise, it looks very nice. And the diet sequence, the first week is a liquid diet, second week will be soft diet, minced diet, third week will be rice and gravy diet, and the fourth week, anything is fine. That's it, it looks fine. Okay, we continue. Why his mic is off? He can talk to me if his mic is on. It's not disconnected. Can you give this to Shoaib to put a new battery? Maybe the battery's off. And ask him to buy 4 9-volt batteries for the future. Dr. Asha, can you give this to Anne? I want you to be part of this. It's important.
Uncomplex. These are attracted to MHC1. You can kind of say this is what brings them to the cells that have cancer that have expressed antigens on their MHC1 complex. So most of the time, CD8 positive T cells are cytotoxic. Cytotoxic T cell. And oftentimes, before a cell gets activated, they just describe it as a CD4 T cell or CD8 T cell. And then after it becomes, for example, a cytotoxic T cell, after it becomes activated and starts wanting to kill things, then they can call it cytotoxic. But this is all work related, the general idea.
You know what's the general idea? This guy builds and helps to build. This guy helps to kill.
But just remember what they do. This guy, you just said it, he'll bond, he wants to bond to the MHC complex. So you have MHC complex plus presenting some antigen. This is MHC1 right here. We learned in the last video, every nucleated cell in the body expresses an MHC1 complex. So this is the case where something wacky is happening inside the cell. Maybe a virus is infected it, maybe it's cancerous. It's just, it needs to die. Otherwise, it's going to keep producing protein, keep producing viruses if it's infected by a virus, or otherwise it's going to keep dividing if it's a cancer and infect the rest of the body. So the CD8 kills infected cells, kills, I'll say bad cells. Cancer leads to infection, kills bad cells, cells that are, if you don't kill them, you're going to keep producing viruses that keep splitting and spreading.
How does it kills? How does it kill? By sending more? Macrophages, anything that can destroy when it comes to implant dentistry, things that can eat the bone away, it will be sent. So it will enhance the bone resorption.
Cancer. Well, T cells, special antigen presenting cells. So I was doing a genetic cell right here because there are some best antigen presenting cells, and they have MH2 complexes, and it's digested some antigen and presents it right there. And then that activates the helper T cell. And then when the helper T cell, all of these guys, once they're activated, they all start differentiating to effector and memory cells. An effector helper T cell does a couple of things. So when we're talking helper T cell, it can activate can activate B cells and also releases cytokines. And obviously this guy gets activated, he'll also start releasing these chemicals, which are really those alarm bells that tell other people to really get in gear. Maybe B cells and cytokines and T cells start proliferating more rigorously. Actually, part of the T cell.
He's talking to us. Yes, we can hear you clearly now. Any questions, Dr. Anas? Did he say anything? Did he say anything?
Cytokine T cell activation can be assisted or kind of be given a boost by the cytokine. So this guy is the alarm bearer. While the CD8 cells or the cytotoxic T cells, when in their effective mode, they kill cells. Of course, in the memory mode, there's just a bunch of copies of these originals around that are ready more than they originally were, so that in the future, if something like this or something like this occurs, they're going to be activated faster, they're going to be bumped into faster. So hopefully that clears up.
You understood the memory part? That's what I want you to. That's one very important thing, that they get into a. Yeah, it looks good. I think mainly she's happy that she's going to leave the chair after all these hours and go home. You can see her smiling, actually. Yeah. I think if he, I switch it off, if he takes a very thin burr and he makes a small space between the teeth, only 2 millimeters from top, not the whole thing, she will look much nicer. Just that 2 millimeter will make a big difference. But anyway, she will come for suture removal. Dr. Anas, the suture removal is 1 week? After how many? 10 days? There is no bone grafting. Is there any bone grafting done? Okay, then why 10 days? It should. I think 7 days, if no bone grafting, is sufficient. Also, we can see how she's coping up with the teeth, the provisional teeth, and then if she has any concerns or comments. Yeah, that was good. I saw the articulating paper coming out. In that 7 days, when we remove the suture, I think we will make this to look nicer. Okay, so back to the memory. So these guys will alarm and try to build the problem. They'll help. These guys will kill any bad things coming. And if you solve that problem, okay, you put bone grafting, you extract the tooth, and then few years pass by, and there is another bacteria, another defect. Immediately, these guys will do the same thing because they remember 5 years ago when this happened, this is how they behaved. Let's continue. Okay, this is one. The second video is only, I think, 2 minutes. Where is my memory history? Yeah, this one is very short. This one is when you ask for a test, this is what you should be careful. This is what you want to know. Channel. For your information, this video was created on 07 July 2018. Here is the explanation.
to CD8. A normal CD4-CD8 ratio is 2.0, with CD4 lymphocytes equal to or greater than 400 millimeter 3 and CD8 lymphocytes equal to 200 to 800 millimeter 3 dots if your ratio is high.
Wait, remember, this 400 to 200 is the good thing. When it goes to 800, then the ratio is no longer 2. The ratio becomes reverse, correct? Or if it's 400, if this becomes 400, then it's 1. You with me? No? We will do it in other cases. We will show you the significance. No, in refractory periodontitis. There is a correlation between a refractory periodontitis and the CD4 has come down. I'll tell you, we'll analyze this after we watch everything.
Higher than 2, it means your immune system is strong, and you may not have HIV. If your ratio is less than 1, you may have HIV.
Okay, now this was the background for what this is the background for what I'm proposing. What I'm proposing now Yeah, you can switch off the microphone if you like. What I'm proposing now is patients come to us with fractured teeth, accidents, with root canal failed or post-encore broken cases. In those cases, we are not very much concerned about this issue. I'm talking about a case that the patient comes with a severe periodontitis and they don't have calculus. They have been coming to your clinic every 6 months for scaling and root planning. Those are the cases that we tend to extract the teeth and do implants and then regret. Those are the people now we are discussing about. Some people call it refractory periodontitis, that no matter what you do, the patient is brushing 3 times a day, flossing 2 times a day. He's being in his dentist clinic every 2 months. Still, the bone resorption is continuous. The easiest thing to do with them is to extract and do the implant. But what happens with these people, many of them, the same scenario is repeated on the implant. Now, what we are proposing here, even though it's very uh, uh, early to be a very common practice, but this is the future. This is what's going to happen within 5 years everywhere. What's going to happen with these people? If you take the CD4 before you extract any teeth and the CD8 before you extract any teeth, before you plan any implants, and you see their CD4 is less and their CD8 is more. From now itself, you know they will not have a good prognosis if you extract the teeth and you do implants. So you try to maintain their teeth as long as possible. If you have to extract it because it's really mobile, then you do the implant, but still you make sure the implants also are maintained every 2 months, every 3 months, more than your other patients. This is what will happen for you if you don't want to invite those cases to yourself. HIV was the only way they benefited from this information. Now they found a correlation between CD4 and CD8 and refractory periodontitis cases who are not having calculus, who are not having any reason why you can remove it and the things get better. You did all the possible prophylaxis procedures. Still the problem, Mehdi, still the problem is continuous. So instead of you extracting and implanting, and then 5 years down the road, you have the same resorption and the same basically failure, you might as well be warned before. So this is something for you to be alarmed. Then what you want to do with this information, it's up to you. This is the explanation of what's going to happen in the future. We started doing it just recently to see if it's practical or not on 2 patients now, but it's too early for this to become a standard of care. One is because all your patients are not, we're not doing this for every case, we're doing it for only selective cases. And also we don't want to promise the patient when they come with so much periodontal problems that once we extract the teeth and we do implant, all your problem is going to disappear. We have seen it that it's not disappearing. Now you can comment, Dr. Ash. No, you said that it's only done. I just wanted to tell you only was done because autoimmune problem. Now we can also predict autoimmune problems when it comes to refractory periodontitis. Any of you are not familiar with refractory periodontitis? You know what's refractory periodontitis? You? No? Yes?
Yes, yes, I
You
do.
know? Tell us.
Refractory periodontitis, it's the type of periodontitis that where everything is healthy in the parameters of calculus of any factors that would be that would categorize the patient as a risk for having periodontitis. It's missing, and it happens without an evidable cause.
Exactly.
Um, some people correlate it to immune problems. Sometimes I don't want to say anything else because I'm not sure on this.
Okay. Anybody else has anything? Dr. Aisha, you want to answer that question?
Also, doctor, there are no clinical
Switch off the
indication.
light. Switch off all the light. Sorry?
Like no clinical signs for periodontitis, like a gum inflammation, redness.
Yeah. They do have bleeding on probing, and they have continuous bone resorption.
And this is doctor genetic or no?
That's what it's. We think it's autoimmune.
So it's genetic?
Could be genetic.
And if, for example, because if a patient, she told me she's afraid that she'll have gum recession because she started, because her mother, they have the same. And when she came to the clinic, she have no calculus, but she have really big recession in the gum.
So for those patients, I think you have to study about CD4 and CD8, and maybe you want to test her. Maybe she has an autoimmune problem.
So we can treat this kind of patient. We can do something to decrease this CD8.
No, but there are ways, but doctors who are into immunology, they can treat, not us. But at least you don't rush extracting and doing an implant. At least you know. Wait, let's just put this on for everybody to see, and then we ask questions. Zoom is, yeah. Now, this is the first patient that we sent for testing the CD4 and CD8. I want you to tell me, the patient is saying, uh, I have pain on the anterior. That's the reason for her visit, actually. What I noticed was, if I remove this wire, these anteriors are going to fall apart. She thinks she has pain, but actually, there is hardly any bone holding to this anterior teeth. She has no idea about this. She doesn't know there is a problem here.
How old is the patient?
50? 50. This she is not worried about. This one is also bothering her because the mobility and the pain is so much. Unfortunately, do we have a periapical of this? Anyway, the bone level is still here. You see it? And she has no idea, no problem, no complaint about this too. And so when I saw this case, she we decided, she's a local and she works in the Ministry of Health, so she has access to CD4 and CD8 tests. So we thought, at least let us start somewhere, knowing if we can see to remove this imbalance or the ratio. If it's 2 to 1, then at least we will concentrate on periodontal therapy, do a proper augmentation, do the implant, and that's it. But if there is an issue with the, immunological problem, we don't rush into extractions and into bone grafting, which we are sure that the memory part, you remember the memory? That memory will come and affect us again in the future. That's what we are worried about. Okay, how would you treat, now you said you have a question. You have a question. Somebody said you have.
I had a question.
Go ahead.
Okay, Dr. Nevermind, can you just answer it?
Yeah. Now I want to hear, what is your treatment plan for this patient? Okay, forget the treatment plan. What is your discussion when the patient comes in? How would you, the patient says, fix my lateral incisor because it hurts and it moves. That's all I have. How would be the conversation between you and this patient?
She just wants
She wants
fix
to,
the lateral.
yeah, she wants to fix the lateral, but how would you start the conversation?
First of all, I have to inform her briefly what the findings that I found, what kind of problems she has.
Okay,
Like a consultation, basically, I'll be giving her.
yes, tell me. I'm the patient. Tell me what consultation.
So by looking to your X-ray here, I can see some problems here and there. First of all, you have generalized recession. I'll be like explaining what is the recession to her and how it is generalized, and how our treatment options are limited here somehow, and we have some problems we might face, and we have to avoid these problems by doing some tests. Let me say the CD4, CD8.
No,
We don't have
CD4
to
and
rush
CD8 is too new for you
for
to even. I think,
consider
yeah.
like realistic treatment.
Let's go like 2 hours ago, before this lecture, and then just continue.
Okay, so regarding the lateral incisor, the one in the quadrant one, which is the upper right, we should have a periapical for that. But I think the bone is already
The bone is here, yeah. The bone is here.
it's like next to the same as the center.
Yeah.
We can see like not X-ray pictures.
Yeah, yeah. Let's see some photos. You're good. Good idea. Let's see some photos. Yeah.
No, because from the X-ray I thought you have attrition, but when I see the scissors, no.
Dr. Why we always, when we have a flared anterior teeth, we have absorption. I noticed when patient is the flaring is decompensation for the occlusal forces.
Wait, you wanna? This is the lateral,
Yeah.
and it's mobile, and it's attached to the wire, but still mobile. Okay, continue.
Um, Doctor, first, all these the upper anteriors they are connected to the wire.
Yeah, upper and lower they are connected. You saw the X-ray.
Yeah. So we assume that if we remove the wire, all these teeth are going to be mobile, and the case is going to be worse.
Yeah.
So she has to be aware of that,
Okay.
and we have to think of an option that would increase the bone and enhance the dental ligaments and attachments in the apical area of the teeth, which is perio basically.
Hmm.
We go for periotherapy. We follow up occlusion also.
And because it's to edge, this one also like
Edge and dorsal.
Slash push.
They're quite on the anterior teeth. No, but they wouldn't call her a rupture as such, maybe because of the actual flaring, lower anterior attrition has taken place. Because you can actually see the cusp properly for the molars, even though they're below a crown, you can see the premolar cusp. They're not flattened down.
Even the canine is not flat.
Flattened down. So no classic drug syndrome. Because we cannot immediately classify it as refractory, so we will talk to the patient about doing some periodontal treatment, watching it over a sequence of maybe 6 months or something. Definitely the lateral incisor will go, but we will not try and replace it permanently, considering the bone levels on the central and putting force on that. So we might just talk to her, say, look, we have to get rid of this tooth. We have to give you something temporarily there. At the same time, we have to try and treat your periodontal health. See whether the bone levels get stopped there. They don't get progressively worse. And then if you're a little confident over a period of time, maybe a year down the line, it's strong enough, you might just go in for putting a bridge there or a Maryland there.
Mm.
Just to say there will be support on the both the things. But with that kind of a bone defect, just going in with an implant, I think will be like, I mean, it's like jumping without a parachute.
Mm.
What's the cause of this resorption?
Which resorption?
No resorption. The patient is not that bad oral hygiene. That's what he's trying to say. This might be a case of refractory periodontitis.
Okay. Anybody else? Because once you tell your opinion, I want to. It's only 15 minutes. I want to say what I told her. When was it? Day before? Yesterday. I want to tell you what I think will be my. But I want to hear all your opinions. What else? Any,
I want to ask you actually,
yeah,
if you get such a case, will you take it?
I got this yesterday.
Yes, yes. I do. Okay. Now, since you have this case,
Okay,
and the patient comes to you asking for you for this lateral incisor, all right?
okay.
Like he wants only to treat this. He has no other issue. But you look at it, you see a lot of problems. And the way to treat it, if you like, would say to go by the book, it's like steps. You know, and this is one of the complex cases.
Hmm.
So you would be telling the patient, this tooth can be treated if we treat the whole mouth, or we can do one thing for you. And this is, I just want you to
I'll
follow.
tell you what I told her,
Yeah.
but I want all of you to not just Sachin and that's it. Nobody else give a plan. I want to hear, even in one sentence, everybody to give your plan if this came to your clinic today. You want to start? Go ahead. Okay, go.
Actually, she have for sure the problem in the lateral. She have the problem in the 4-6 and 3-6. She have very big defect, bony defects in the mesial of the root. Uh, for sure, she will need to do scaling and polishing and give instruction for oral hygiene. She have also this on number, I think 447. Also, she have big class 2, I think. Uh, so that also I think she need to go to ortho because this central that she have central only edge to edge. Maybe by ortho we can put it back, fix the occlusion, so the occlusion not will be only on the central, on the lower central, so it will be divided. It will be much better. Uh, Maybe I will refer it to Perio, so maybe he can do something regarding this one. That's it.
So it's a multidisciplinary. It's not you will. Okay. Retainer, but now it's become split. It was when she did ortho 16 years ago. Yeah,
Maybe she had this problem from the ortho.
could be. She did it many years ago. The ortho. So okay, let us hear the. So because there's only 12 minutes left, I need the last 5 minutes to tell you what I did. So you have 7 minutes. Go ahead.
Maybe we should advise him whichever tools which are moving, we should advise to remove the root pieces and everything. Then
Okay.
we should go for the root canal.
Okay.
And then we should wait for another 3 to 4 months just to see how
But do you guarantee if you remove the teeth, you can place an implant?
in that particular area it's not possible.
Okay, your turn.
So we can, whatever the patient wants, extract that tooth and place graft and
Okay.
later do a implant. But what I was worried is whether the patient is having trauma from occlusion from the bite shoes.
Okay.
Can that be the reason why she got this?
But when they are connected normally, I'm not saying in this case, when they are connected, normally trauma from occlusion doesn't happen because they support each other normally. But in this case, actually, we didn't remove the occlusion. There was another case after this. We removed the, yeah, that we removed the contact. In this case, we didn't touch the occlusion. You're right, because they're connected. But if it was not connected with a wire, immediately you're right. First thing I look is strong. You're right. Then, then, yeah, this is 16 years ago, fixed retainer. She's 50 years old. Aisha, tell me what you will tell her. You refer her to periodontist completely.
Okay, tak tak. It says tak tak. So, and
But could it be a case of bad ortho treatment or bad
so all the
ortho?
ortho treatment.
All this. Okay, now what you do? Okay, it was caused by ortho. What is your role now? Let us hear Asha, and then we come. So what you will tell her? Treatment. First perio, let her go to perio, and then we'll decide. Okay. 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 Your turn. Huh? Sorry. Sorry. Okay. Oral hygiene instructions and perio, and that will solve everything. Okay. All right. And as could be because she lives in Abu Dhabi anyway. No. Ah, this is a lady. Okay. All the teeth. Okay. Wow. See, I wish you were here for the CD4 and CD8. Probably you can follow it on YouTube, because there are, if it's a refractory case and you extract and you do the implant, there is a chance the same memory will come back to the implants. Hyperimmune. Say it louder so they can listen. Both are increased? Ah. Uh-huh. So it's not the 2 to 1. Ah. Both are up. Hmm. Could be. I have to learn more about CD4 now. Yeah. We have to read more about CD4. See, my knowledge of CD4 is not at all even, I'm very ignorant at this point of time. I just know that is something which we have to slowly start looking into when patients like this come in. Now, I'll just tell you quickly, my treatment plan for this lady is she has to be committed to come every 3 months. For first, she will start with the curettage root planning first on every tooth. She should be committed to come every 3 months for normal scaling. Closed. For now, it's closed. But looking at the X-ray, all these, you see those calculus spots, or should I point it? Yeah, do you see them? Yeah, there should be a radiograph making sure all these are disappeared. For example, this has to disappear. There should be another radiograph to make sure all these spots, you see this? So it's not just root planning and then send them home. There should be a radiograph for quality control of the root plan. Then every 3 months, the patient should come for a low-level laser therapy for all the teeth and scaling. The low-level laser therapy should be repeated every 6 months. The normal scaling should be repeated every 3 months. When she comes after 6 months, and the second, the first, second, third, because curettage is done now, 3 months scaling is done, 6 months, another scaling is being done, then we will wait, laser even now, and every 6 month laser has to be repeated. After 10 days from the 6 month from today, we will reevaluate for which tooth has to go and which tooth has to stay. Now, what is obvious has to go with bone augmentation is this and this. This tooth doesn't require bone augmentation. So if things are okay and our CD4, CD8 is within the normal limits, this tooth can receive, yeah, this tooth can receive as a test, just extract it and place an implant. This tooth will have a removable RPD and a Maryland ready, both ready, the maxillary lateral. This tooth is going to be out, cleaned, augmentation done, and some kind of a provisional, either removable in her hand if she accepts. If not, of course, a removable means it's far from the ridge and the palate is taking the load. No pink gum at the neck of the tooth. Yeah, absolutely. It should be 1 millimeter away from your augmentation.
Doctor, I think your idea that you said of using lateral, couldn't it be done like after the first 3 months, this thing, that piece over there, remove, put an implant there, just keep it there for test?
This one?
Yeah.
Yeah.
Saying that after 6 months, if rest of it's stable and even that is stable, then we can be more confident about that.
Yeah, but the problem is this is hurting her like hell. She cannot sleep from pain. I have to remove this as soon as possible.
Yeah, remove that and before committing to doing any other implant anywhere else.
Yeah, yeah.
Do it in that place.
No, but I'm not.
To try and
Yeah, but I'm not putting implant here till I have a good health.
Not there.
Ah.
I'm saying that root piece there
Yeah.
for the 1.5.
Okay.
We remove that. We put an implant
Yes.
there, and we leave it there, saying that while the rest of the work is going on, simultaneously we can also assess at that position whether there is bone loss, whether there is some aggressive.
Good idea. Good idea.
So that we're safe from a bad decision
Yeah.
later.
The only thing is this is urgent.
Yeah.
Yeah.
That goes off first.
Yeah. And then this one will be extracted and augmented and left. Of course, class 2 fillings. This tooth, we are not in hurry in extracting it because it's not as mobile as, as the patient is complaining about it. So what we are hoping to do from actually yesterday, the patient will be taking 20 milligrams of doxycycline daily for 6 months. And we are going to check chlorhexidine varnish we couldn't find here, the 10%. So we are looking for it. Once we find it, she will be applying chlorhexidine varnish around this area. And we will see the pocket depth 6 months from today. Laser is full mouth, every 6 months. Is it?
It's like a chips. It keeps on.
No, that barrier chip is doxycycline. Or the chlorhexidine also?
No, it's chlorhexidine
I
chips.
thought it was doxycycline. There's something called as barrier chips. Barrier chip.
It's in a granule, in an injection format?
No. It's just like, you can just put it into the surface. Doxycycline, right? Yeah, that's right. It's blue thing. Chlorhexidine has blue thing. Slowly release. Doxycycline is barrier chip. And I've seen one place they were also talking about instead of the chlorhexidine varnish like that, you can actually make something like a bleaching tray, use the chlorhexidine gel and ask the patient to put it in their mouth and like a bleaching tray.
How will the color change after a while?
That's the only issue.
Okay, so this is the plan for this lady from our side. Nadine.